All right, everyone, we are at 6 o'clock. I wanted to say thank you for joining us for our first session of our continuing education webinar series, Insights into Serious Mental Illness, a comprehensive seminar series. My name is Dr. Stavara Haley Clark. I am the Interim Associate Dean for Academic and Student Affairs, Director of Online Education, and Associate Professor in Teaching here at the VCU School of Social Work. I wanted to give thanks to Dr. Cassie DeSena Jacobs for helping me put together this series for you all on serious mental illness. Tonight, we are going to embark on a journey of understanding that's going to be led by Interim Dean Gary Cuddeback, a distinguished expert in the field. So from 6 until 7:30 tonight, Dr. Cuddeback will guide us through foundational aspects of serious mental illness. This session marks the initiation of our 7-part series, promising profound insights into critical topics such as global perspectives, racial trauma, crisis intervention, children and adolescents, substance use, and an intersection with the Virginia legal system. One of the things you all will see is that we've provided an opportunity for you all to gain a digital badge, while also for our professionals to get continuing education credits. When Dr. Cuddeback gets started, you will see I'm going to put a link in the chat, and that is going to be for you all to fill out so that we can capture your attendance. The National Association of Virginia requires us to get an official list of attendees, as well as so does our online continuing professional education office, so they can offer digital badges. So I will drop that link in the chat for you as I turn it over to Dr. Cuddeback. And after tonight's session, everyone who fills out that form will also receive an evaluation of the session. So without further ado, I'm going to turn it over to you, Dr. Cuddeback.
Thank you very much, Dr. Clark. And I'm delighted, absolutely delighted to be here. As Stavara mentioned, this is a new initiative that we're launching. Cassie DeSena Jacobs has been a big part of this. So just delighted that everybody is able to join us this evening. I'm going to see if I can manipulate so we get that, and hide presenter view, and let me see if I can hide floating meeting controls. Okay. And then get rid of that. Stavara, how's that look? All right. So again, delighted. This is the first in a series of lectures over the next a couple of months that we hope to continue well into the future of the school as well. So thank you again for joining. I want to tell you a little bit about my background, and I want to promote the School of Social Work here and really find ways for the school to engage in the community here in Richmond and beyond, particularly around mental health issues. So I'll describe a little bit about myself, but really want to be accessible to folks in the audience. If you'd like to talk with me, if you want to follow up on anything I might present, or find ways to get engaged with the school, particularly around our mental health initiative. So graduate of Furman University, go Paladins in 1991, worked in a rural community mental health center in Florida for a couple of years, which really sowed the seeds of my interest in social work and evidence-based practices and effective mental health services and interventions. I went to University of South Florida for a M.S.W. and Master's in Public Health, and then started working before I finished my Ph.D., joined a health services research center at University of North Carolina. Started that in 2003 and finished my Ph.D. from the University of Tennessee in 2004. I matriculated through UNC as an assistant, associate, and full professor. And then after almost 20 years at UNC, made the terrific decision to come here to VCU, first as Associate Dean for Research and Professor, and then now I have a number of titles, and just delighted to be Interim Dean and looking forward to great things here at VCU. There's lots of opportunities here on campus for the kind of research that I do, and there's opportunities here in the community and with the state. So that's a little bit about me. Um, uh, Nobody cares about this part, but the kind of research that I do is now intervention research. So I try to do um, intervention studies, putting evidence-based practices into the community and then studying the impact of those practices. So I'll talk about the criminal justice or criminal legal system quite a bit tonight as well. And a lot of the work that I do, because there are so many individuals living with mental illness in the justice system, a lot of what I do is intertwined with the justice system. So delivering interventions and studying those interventions in mental health courts, jails, prisons, probation and parole. So I've focused mainly on intervention research, really adapting and developing interventions for people with severe mental illness to improve their outcomes, hopefully keep them out of the criminal legal system, but serve them while they're there and as they are released. So it's a little bit about my research background. So if you're a provider out there and have interests in talking about program evaluation or research, or what you have with respect to services for individuals living with mental illness, I would absolutely love to hear from you. Okay. And we'll have plenty of time for questions and answers at the end. A little bit about the School of Social Work here, in case you don't know. And again, I really want to find ways to engage the community and be accessible to you. But we have faculty here who are focused on the strategic priorities of the university. You see those in the inner circle, enriching the human experience, optimizing health, achieving a just and equitable society. And then we have faculty working on different social problems with different populations tied together with the theme of social and environmental justice. So we have faculty working on refugee mental health, housing stability in underserved populations, individuals living with intellectual and developmental disabilities, outcomes of kids in the child welfare system. And you can read particularly the text in red there. So we have a faculty working on lots of different issues that are of great impact and import in our community across the state and nationally and internationally as well. All right. So let's get into the content and a little definition and sort of setting the groundwork for the rest of the discussion. Severe and persistent mental illness. And this definition comes from back in the 1980s when National Institute of Mental Health and other organizations were focused on defining and counting individuals living with mental illness. So services, the community mental health system, state hospital system could understand a little bit more about demand and capacity. So this definition back in the 80s proposed the 3Ds, so diagnosis, disability, and duration. So when I say SMI or SPMI, this is really what I'm talking about in the population that I'm focused on with my research. So diagnosis, typically schizophrenia, schizoaffective disorder, bipolar disorder, delusional disorder, psychosis. These are the more debilitating, symptomatic, speaking, diagnoses. So one of these diagnoses, evidence of extreme disability or impairment, and evidence that individuals have been impaired by these diagnoses for quite some time. Now, these bullet points below each of the 3Ds is creative ways. So a lot of my early career, I've used large administrative data sets, such as Medicaid claims data, to examine policies, publish papers regarding folks living with severe and persistent mental illness. But in Medicaid claims data, as you might imagine, there's not a variable that indicates severe and persistent mental illness, which is the 3Ds. However, there are ways of getting at that by proxy. So if I see a diagnosis of schizophrenia, If I see a pattern of hospitalizations or a long-term stay in a state hospital, that's indication of disability and someone unable to remain in the community without supports. And then if I see evidence of supplemental security income or SSDI, um, then it is an indicator that these individuals have had these disorders long enough to qualify for these programs. And I don't have to tell anyone on the call, for those of you who work with these programs, that it takes a long time and a lot of paperwork and a lot of supportive evidence to get folks enrolled in these programs. So you really have to have a history and a long history to get these benefits. So that's the groundwork, the framework for severe and persistent mental illness. So think of the 3 Ds and the more debilitating among the disorders. So schizophrenia, schizoaffective disorder, bipolar disorder. I also want to talk a little bit about, unfortunately, the number of issues and the number of things that can be addressed with this population. So I think of my program of research and like an umbrella. So the umbrella being individuals with severe and persistent mental illness. And underneath that, unfortunately, as I said, there are a lot of issues to study. So the effectiveness of mental health services research, involvement with the criminal legal system. This population experiences a lot of health disparities around not only outcomes, but access to and utilization of services. Community reentry from institutional settings, such as a state hospital, local hospital, criminal justice setting like a jail or prison. This is a highly stigmatized population, both internalized stigma and socialized stigma. I'm going to talk about criminogenic risks, which gets into the legal side and the criminal justice approach to serving this population. Recovery has been a movement that's been active for the last couple decades. It used to be, we thought, individuals with severe and persistent mental illness would be confined to large state hospitals for the duration of their lives. And we now know that's not true. Individuals with severe and persistent mental illness can recover and lead meaningful and productive lives like the rest of us. Research about the financing and delivery of mental health services, interpersonal violence. We have very few interventions that are effective at the intersection of interpersonal violence, domestic violence services, as well as severe and persistent mental illness. And these are two separate service systems for the most part. But women with mental illnesses are more likely than women in the general population to experience interpersonal violence, and they're vulnerable more so than the general population. Physical health care and integrating either health services in a co-located or reverse co-located fashion. Aging, financial literacy, substance use, rates of substance use are super high among this population. High rates of homelessness and housing. So it's a population that's got a lot of needs, that is vulnerable, marginalized, really a population, one of the most important populations, I would argue, that social work serves and community mental health serves. So a lot to study. All right, Rebecca, I see your hand is raised. Go right ahead. I don't mind.
Okay,
Yeah,
so based on these topics that you've discussed for areas of research,
yeah.
with all of the state hospitals that are being closed in the state of Virginia, is that gonna factor into any of these areas of research because they're closing what
Yeah,
is like 4 state hospitals in the past couple years? So
right.
that's affecting the placements where people with severe mental illnesses can go. Do you have any thoughts about that?
I do. That's a good segue, Rebecca. Thank you for that question. For this one, excellent. And this, Rebecca and I did not plan this ahead of time. But if you think about where individuals with mental illness resided 50 or more years ago, they were in our large public state hospitals. So, Rebecca, the quick answer to your question too, so I don't forget, is yes, all of those issues are that I described are even more important given folks are being released, or they can no longer gain access to our shrinking state mental hospitals. So, and the point I'll make there is the public mental health system is really shrunk. If you think about state hospitals, and say what you will about them, if you think about them, care and treatment were together, meaning they got meals, they had recreational opportunities, they had a place to sleep, so their care was there, and they also got treatment. As we deinstitutionalize these hospitals now, care and treatment are very much separate. So you go to one place to get physical health care, you go to another place to get housing supports, you go to a separate place to get mental health and maybe substance use treatment if it's integrated. You go to another place to get Medicaid benefits. So all of these Byzantine bureaucracies that are siloed, that each have their own funding streams that they're very protective of, they each have their own eligibility requirements, would be hard for all of us to navigate, let alone someone with a serious mental illness released from a hospital or a jail or a prison. So all the issues under that umbrella, Rebecca, you're right on that they're even more important now. So care and treatment are now separate. People are diffused into the community. Unfortunately, now the only place they're well integrated in is the criminal legal system, which for the kind of research that I do, the kind of mental health services intervention, it's the justice system that where I go, and I'll talk more about that later, to find these folks and to help these folks. And if you think about it, the fates of individuals living with severe and persistent mental illness are closely intertwined with our local criminal justice policies. If we pass a new city ordinance against panhandling or solicitation or anything, it's going to impact those who are homeless, those who have substance use disorders, those with severe mental illnesses. So you tweak the justice system in ways that, no pun intended, but captures more marginalized populations, which is a problem. I don't know if you've thought about it that way, but if you think about criminal legal system and its policies, it really impacts first and foremost those who are most marginalized. And unfortunately, the criminal legal system is a place of last resort. So if we're having trouble accessing state hospitals and treatment, the jail has no front door. Anyone who wants to get in, no pun intended, can get in. So it's the justice system that cannot refuse anyone. When there's legal activity involved, or even when there's not. Jails have also become, in the justice system, a public health outpost. Unfortunately, for some folks living with severe and persistent mental illness, the justice system is the first and best chance to get diagnosed with something, either a mental illness or a chronic physical health problem. These institutions are constitutionally mandated to provide treatment. So there's almost a perverse incentive to not screen for stuff, if you will, because if they find it, they got to treat it. An unfortunate story that happened years ago in North Carolina, there was a gentleman that decades before had escaped from a work farm. 40 years later, he turned himself back into the prison system because he developed cancer. And he knew the only way for him to get treatment would be the justice system, because he was had absconded and didn't have benefits, insurance, and so forth. So a sad testimony to kind of where we're at. Criminal legal system really, unfortunately, is a place, as I'll show next, yes, where a lot of our folks living with mental illness reside now. I'll pause there for a moment if anyone's got any questions up until now before digging into this slide. So
I just wanted to comment on what you had said, like how like the criminal justice system is becoming like a place for people to like receive diagnosis. I think too, like a lot of where the blending comes together too is that a lot of mental illness is mistaken for crime.
Yeah.
So like somebody who's going through, let's say they're schizoaffective, they're going through a really bad episode, it's displaying as disorderly conduct or something along those lines. So, and because, and I don't want to say not all cops are trained. I know they're slowly working towards that. But a lot of like laws and mental illness diagnosis mixes together. And
indeed.
And it's hard to make a distinction because they need help, but there's not enough resources for them to receive mental health help. So unfortunately, jail is the only last option.
Thanks, Rebecca. You made my point well. You did my job for me. Yep, well done. So on any given,
And
oh,
sorry,
go ahead.
sorry.
That's all right.
I was just gonna say, I also know that even if you do go to jail and you get diagnosed, not all the time do they let you take like medication with you or any treatment services you got in jail with you out of the jail, which sometimes causes people to go back.
Indeed. That's exactly right. Matter of fact, if you ask the local sheriff, he'll say treatment, medication, trying to get medication for folks is one of their biggest budget items that, I'll make a point in a little bit that this was a system never intended to be the custodians of care for marginalized populations like individuals with mental illness. But unfortunately, they are the custodian, they being the justice system, custodians of physical health care, substance use, mental health care. And it's a system that was never set up to do so. So if you look at this on any given day, there's about 37,000 individuals with severe mental illness in our network of state hospitals. Juxtapose that. How many English majors out there appreciated that I used the word juxtapose? All right. Thank you. I'm here all week. So juxtapose that with over 250,000 in prisons, 130,000 in jails, over probably 1.5 million by this point on probation and parole. So by far, there's more individuals with mental illness in the criminal legal system than our network of state hospitals. Now, I put the red oval around jails just to demonstrate that I could do a red oval in PowerPoint. But really, if you know anything about jails, those are short-term, quick turnaround facilities. There's about 3,400 jails across our nation, county jails. And the number of annual admissions to these jails is probably around 14 million. So if even a conservative estimate, about 10% of those are individuals with mental illness. So we're talking about 1 million folks in jails, revolving door in and out of the jails. And Rebecca made this point. Thank you, Rebecca. We have all kinds of interventions now that the criminal legal system has developed in response to this problem. So we've got crisis intervention training for local police officers designed to educate those officers and try to divert folks into the mental health system rather than the justice system. Not every county has these. Not every county has a CIT trained officer on every shift at every hour. So this is one strategy, though, that police have developed. We have specialty mental health courts. I'm still learning the landscape here in Virginia. I've heard there might be a handful of those.
Oh, I actually know. So I know in Fairfax County, they have what's called the mental health docket, which is to ideally subvert somebody from ending up in jail. So like if you have a diagnosis of a mental illness or a serious mental illness, the idea is you still go in front of a judge, all that, but you're working, like you're doing certain things with them to the idea is by the end you will get all your charges dropped, but they also help you get set up for if you need help finding housing, etc., getting you set up with services. That's the ideal. But I don't know how many counties
Yeah,
I,
in state of Virginia have it.
I'm actually interning with that docket at this moment at the RACSB in Fredericksburg.
excellent.
They have one in it's the Spotsylvania specialty docket, a behavioral health docket, and currently they're like trying to spread it to like King George, Fredericksburg, and a few surrounding areas that are also already like know a little bit but haven't been like intertwined with it just yet or using it. So yeah, I know that about that. So those counties are trying to spread this docket that we've had for about a year.
Excellent. Yeah, and it speaks to the justice system trying to mount its own service system, basically, if you think about it. So that's good to hear. Rebecca, if either of you want to be in touch after, I'd love to hear more. And Rebecca Withrow, I see a VCU logo. So are you a student here?
Yes, I'm a graduate student right now.
Terrific. Okay.
I am as well. I do the online program.
Oh, terrific. All right. Well, let's talk. Jails now are doing screening and treatment. They're trying to do more robust discharge planning, and they have special mental health pods, and they are trying to provide medication and substance use treatment while in jail. You know, jails just want to keep folks safe and process folks, right? They want to get you in and out without harming yourself or anyone else as quickly as possible. So they're not particularly interested in what happens to you when you're released. So they're not putting together um, uh, discharge teams that are going to follow you out in the community and make sure you have housing and so forth. So, you think about the criminal legal system, and it's partitioned and segmented, and each part has a different role. In prison, we've got special treatment pods. North Carolina um, is requiring CIT training, crisis intervention training, for all its correctional officers, for example. And then probation and parole, and I'll talk more about this at the end, but we now have a specialty mental health probation counties all across the country. And I'll talk some about this at the end. And that's what I've been doing in North Carolina for the last 10 years or so, and hope to begin to do some of that here in Virginia since I arrived. So here's the picture of where all our folks living with mental illness are penetrating the different parts of the justice system and the response that the criminal legal system has had to this. Here's a slide. These are old data, but this is one of my earlier studies. This is King County, and these data are old, obviously, but I don't think the picture has changed too much. The point I want to make here is there were 117,000 jail admissions over this 5-year period. And a small slice, a very small slice of those were individuals living with SMI who were in for any kind of violent felony. So that's the red pie slice. So the take-home message here is the media likes to sensationalize and perpetuate stigma that all individuals with mental illness are violent. And if you look at a jail population, it's just not, they're not filled jails with violent, mentally ill people. The felony and the violence can happen, almost innocuously or subtly. So if an individual with mental illness is in, a local park, disheveled, disoriented, maybe talking to themselves and approached by an officer, hey, Gary, let me get you some help. Let's walk over here to my car and let me see if I can connect you to resources. And I shirk the hand of the officer off my arm, that's assault on a government official. It could happen that easily. And once these individuals get enter the justice system, the criminal legal system, it's much harder for them to get out than maybe other groups. So we're talking about SMI, and then you layer on the justice involvement, and it makes things even more difficult to advocate, to serve, and to help these individuals. All right, lots of complex needs of individuals living with severe mental illness, absent the criminal legal involvement. So just in general, lots of social stigma, social isolation. These folks often have a difficulty and severed relationships with family. The unemployment rate for folks with severe mental illness is probably 85%, which is just extraordinary. For why that's tolerated, I'm not sure. Lots of substance use, lots of chronic physical health problems, lots of homelessness. You layer on the justice involvement, and all of these problems are exacerbated. So substance use among justice-involved individuals living with SMI, probably 85%, and that's not an exaggeration. Probably substance use, and I'll talk about criminogenic risks and needs later, but I would argue that's the primary driver of justice involvement for individuals with mental illness. It's substance use related stuff, possession, intoxication, and so forth. All right, so I hope I've painted a picture of the complex needs of this population. Here's a study I did a while back. This is a sample of 200 individuals on probation who had a serious mental illness in North Carolina. And we looked at social support and bifurcated this sample of 200 into low and high social support. And as you can see on the left, those with low levels of social support, the red bar, less likely to engage in mental health services compared to those with high social support. And then those with low social support were more likely to have a diagnosis of post-traumatic stress disorder. So I'll make a point in a moment that PTSD is really an issue for this population. And then the graph on the right, in terms of their mental health functioning as measured by a symptom checklist, you can see folks with low social support are functioning more poorly, as evidenced by higher scores on this mental health functioning than those with lower social support. So it speaks to the need to engage these individuals. They need social support just like everybody else, but they're less likely to have more difficulty obtaining it and maintaining it. All right, so there's social support. Cumulative trauma. This is a remarkable finding. This again is the same sample of the 204 individuals on probation. And part of what I asked in the study was traumatic experiences during their lifetimes. And they had up to 18 items they could respond to. And I just picked the top 4 just for illustration. If you look at this yellow bar, the total sample, 80% experienced a physical assault. This is 80% of 200 individuals with mental illness who are on probation at the time. 61% assault with a weapon, 50% sexual assault, 40% life-threatening illness or injury. 90% of the sample experienced at least one violent interpersonal event, which is just remarkable. The rate of trauma among the general population, or PTSD rather, is 4 or 5%. With this population, and this is the red bar, 50% of this sample met diagnostic criteria for post-traumatic stress disorder, which is 10 times the rate in the general population. So a highly vulnerable, highly traumatized population. And now let me connect this back to criminal legal involvement. That's not the place to get trauma treatment, right? So these folks are involved in the justice system, in jails, prisons, where trauma will go undiagnosed and untreated. All right, Mariah.
So with this, are these the statistics for after they are diagnosed with PTSD, the trauma that they're more likely to receive, or is this the trauma that caused the PTSD?
So at the same time I asked about these events, Mariah, I also gave them a diagnostic interview, PTSD interview. So I'm collecting these data at the same time. And then these are just associations. So what I asked them was, in your lifetime, have you experienced any of these 18 events? And then I also gave them an assessment for post-traumatic stress disorder. So the trauma, PTSD happened, prior or as a result of these events, but the temporal nature of how they occurred might have been a year before, it might have been 2 or 3 years before, and there might be cumulative traumatic events as well. So that's not well teased out here. Before I move on to other questions, does that make sense, Monica?
Yes, I think so. Thank you.
Great, you're welcome. All right, I see Jordan and then Jessica. Go ahead, Jordan.
Hi, so I actually have my master's degree in forensic psychology, so I did a lot of research on mental illness in the criminal justice system, and I know one of my last papers I did was about the victim-offender overlap, so kind of going on this topic, a lot of offenders have been previous victims to crime, but they never got the resources and whatnot before, so that's kind of what led them to engage in criminal behavior and whatnot.
Yeah, that's right on. There's one of the criminogenic risks that we'll talk about is impulsivity, which results, is a symptom of undiagnosed, untreated trauma, right? And that leads to criminal activity, or activity that's criminalized at least. So thank you, Jordan, for that. And then Jessica.
Hi, I'm a M.S.W student at VCU, but also a UT grad.
All right.
So go balls. I wasn't sure if I had missed it. Did you indicate if this was primarily men, or was there a gender notation?
Yeah, so these are men and women, and the
Okay.
sample is about half and half. And if you look at the citation for that paper, we break it down by, and this is an important question, Jessica, you're right. We break it down by different experiences based on men versus women. And the women, of course, more likely to experience sexual assault, interpersonal violence, where the men were more likely to experience the physical assault and assault with a weapon. So if you think about treatment and safety planning and some of the other things, then you might have a different response for men versus women, or additional responses based on gender. So thank you for
Great.
that.
Thank you.
Yeah. What a great interactive group. Thank you so much. All right, cumulative trauma. So population with a lot of substance use, homelessness, unemployed, social stigma, and now we see trauma. So I'm painting a picture for you. Physical health problems. This is another study I did where I compared the disorders and diagnoses of a general population versus a SMI without justice involvement versus SMI with justice involvement across the board. And I looked at more disorders, but this is illustrative of the points I want to make. These individuals are more likely to have infectious diseases, blood disorders, skin disorders, more likely to experience injuries. Now, if you think from a public health perspective, you got someone in a jail being treated for a blood disorder or an infectious disease. They start on treatment, but they're released before treatment can be completed. There's little coordination in most places between local jail and local public health. Calling up, hey, Gary got halfway through his treatment for tuberculosis. He needs somebody to pick him up in the community and continue. That kind of oversight and collaboration, unfortunately, doesn't help. So these in particular things we don't want untreated in the community, right? So individuals with mental illness, justice involved, more likely to have these. Now, this is not, I just want to caution, and folks know this is not causation. I'm not saying that justice involvement causes any of these things, but they're associations. So again, when you layer on the justice involvement for whatever reason, the probability of these issues being exacerbated in the population is greater. All right, Stavara.
I just wanted to point out that there was a question in the chat for you, and I'll read it out.
Thank you.
It says, were these issues identified as causal or contributing to the SMI diagnosis, or identified after diagnosis?
Yeah, great question. So not causal, but associations and concurrently. So this is a study using linked administrative data. So Medicaid claims, and then community mental health data, and then jail data. So I linked those together. If you go back to the 3Ds, I used that framework to identify folks with SPMI. And then I could see, based on their Medicaid claims, who had treatment for these, who was involved in the justice system, and who wasn't. So it's not causal, and I'm looking at SMI and these physical health problems concurrently, if that makes sense. All right, so now we have a very sick population. These aren't folks who go to the routine primary care checkup every 6 months. They don't go to the doctor when they have the flu. They often don't get flu shots and regular routine care like the rest of us typically do. So this is a physically unhealthy population that doesn't access or utilize care until often these problems are really serious. A lot of diabetes, cardiovascular issues. These folks often, they'll get detected with these disorders at very late stages. And then these individuals generally treat the emergency department as their primary care. Okay. So then service needs, same sample of probationers with living with mental illness. And I asked them if they had unmet needs. And the red bars, if you focus on that, 65% of the sample had basic needs that needed to be met. 70% had medical care that they needed. 70% had dental problems that they needed care for. And I think I read that dental pain is one of the top 3 reasons that folks go to the local emergency department, and I can attest to how painful dental pain can be. But it's cardiovascular issues, back pain, and dental pain are the three reasons that folks frequent the local emergency department. So lots of folks needed outpatient mental health. Lots of folks needed medication, and so basic needs that needed to be met among this population. A lot of these folks, if you look at this graph, don't have a valid driver's license. So if you layer on probation, where you have to do stuff, probation officer needs you to get go to treatment. They need you to get job applications. They need you to do things. It's awful hard to do when you don't have transportation, especially in our more rural areas that have limited public transportation. A lot of these folks are transient. They do not own or rent their own home or apartment. Lots of couch surfing. They need Medicaid, but engagement with the justice system, folks often lose their Medicaid, or they can't maintain it. So just a needy population. And then if you consider this in the context of all the other stuff we've talked about so far, the stigma, social isolation, chronic physical health problems, substance use, unemployment, homelessness, it really paints a picture of a very needy population that is a challenge to serve, where there's not enough services out there. So I'm probably speaking to lots of folks in the audience that know all of these things better than I do. So paint a picture of the complex needs of this population. All right. Also, when you layer on the justice involvement, and this isn't causal, these are associations, and these are data from a large agency that I used to work with in Ohio that served folks using assertive community treatment services. So I looked at justice involved services versus non-justice involved, and you see a harder clinical profile. Folks who have justice involvement more likely to have schizophrenia, more likely to have antisocial personality traits or disorders, more likely to be homeless, more likely to have substance abuse. So again, it's a harder population to serve at a time when our mental health system is in need of more resources. All right. So I think that's the end of painting the picture of the complexity of this population. A lot of the justice, criminal justice initiated treatments that I showed on that one slide with all the people in the different parts of the justice system they're focused on connecting people with mental illness back into mental health services, as if we could only get folks mental health treatment, they would stop being involved in the criminal legal system. And I often am concerned that the criminal justice system will overemphasize that at the expense of other things, which I'll talk about later. We all know that often for these individuals, it's not mental illness that gets them involved with the criminal justice system. It's all the other stuff that goes along with having a severe mental illness, like homelessness, like unemployment, like not having an income, like the substance use. So I'll talk more about that for a little bit. But interventions focused on getting folks back into mental health services. Some states have expedited Medicaid restoration policies. These are data from the state of Washington. So if Virginia, I don't know if Virginia is a termination state, a suspension state, and what our prisons, for example, do with folks who have Medicaid when they're admitted. These are data from Washington State, which has a expedited restoration policy, meaning that staff will start Medicaid paperwork prior to release. So once folks are released from these institutional settings, prisons, jails, state hospitals, paperwork is started. All they have to do is show up to their local Medicaid office and complete turning Medicaid back on. Thank you, Rebecca. Hang on just a sec, and I'll finish describing this, and then I'd like to hear your question or comment. If you look at this, outpatient service use 30 days post-release for those with, in the green bar, who were approved for expedited Medicaid, and those without, looks pretty good. What doesn't look so good, so state hospitals, for example, 90% of those who came out with Medicaid had some services at 30 days post-release. Look how poorly we're doing with prisons. Even for those who had Medicaid turned on, less than 40% are getting services within 30 days. And these are folks who were receiving medications in prisons or receiving treatment. Jails, not too much better, but this paints a pretty stark picture of what it's like for these individuals being released from these settings. Okay, Rebecca.
I was just gonna say, most of our clients do have Medicaid in the, at least when they're in the system in our programs.
Okay,
I just wanted to say that.
great. Thank you. Okay, so one place of advocacy is we can advocate for expedited restoration program here in Virginia, or a suspension rather than termination of benefits, and so forth. Okay. Well, what if it's not just about mental health services? And I mentioned criminogenic risks earlier. So these are the things that criminologists and sociologists are focused on. And this is after decades of research distilling down the what they call the 8 factors, or big 8 factors that are involved with that are associated with criminal legal involvement. The top 4 are bolded. Those are usually the focus of cognitive behavioral treatments that the justice system uses to address these things, like antisocial behavior, antisocial personality, antisocial cognition. Then you'll see substance use, leisure time, lack of education and employment. What you'll not see here is mental illness. Mental illness is not a criminogenic risk, right? Not on the list here of the 8. However, is there a synergy between mental health and criminogenic risks? And there's evidence that individuals with mental illness have this same configuration of criminogenic risks. But what is the synergy between having a severe mental illness and the intensity of these criminogenic risks? Well, here's some data from state of North Carolina in a paper I published recently. And you look at some of these criminogenic risks: substance use, antisocial personality, dysfunctional family history, impulsivity or self-control, which comes from the undiagnosed, untreated trauma we were talking about earlier, and antisocial values. And across the board, the red bar, individuals with SMI, you can see there are higher levels of these criminogenic risks. So you get a system that's not well equipped to manage individuals with mental illness. Then you get all of these complex needs. Then you get elevated levels of these criminogenic risks. And that paints a picture of the wrong system for the wrong folks at the wrong time for the wrong reasons in terms of trying to treat, advocate, serve these individuals. So these are what criminogenic risks look like among probationers with and without mental illness. This same pattern holds true for individuals in prison, with the exception of the antisocial personality trait. So prisons are a place where you have to comply with the rules, right? It's structured. You have to do what correctional officers say. You need to respond to commands. You need to live in that environment and operate in that environment, which is something awful difficult for an individual with a severe mental illness who's not getting treatment, who's hearing voices, who's got a diagnosis of schizophrenia with paranoid features, and then layer on that all of these additional elevated criminogenic risks. Indeed, these folks don't do well in prison settings. These are data from North Carolina for the first 6 months. Individuals with SMI in the red bar, they're twice as likely to have any infraction over the first 6 months and have significantly more infractions than individuals without SMI, which means they end up in administrative segregation or isolation. They get sanctions, just bad outcomes, even in a prison setting. And just these are the top 5 infractions: disobeying orders, language, unauthorized tobacco fighting, substance possession. You wouldn't think there was tobacco and substance possession in, or at least substances in prison, but for sure there are. Okay, so now we have these complex needs. We've got elevated criminogenic risks. We've got a bad setting for them to be in. I guess I don't have any good news to share, I guess. All right. Well, so I have this, I mentioned mental illness is often not the reason that folks have criminal legal involvement. And I have this way of characterizing what folks need. And I think this will resonate with you. If we're thinking about addressing social determinants of health, and you can cross out health and put social determinants of justice involvement, folks need a bed, a buddy, and a job, right? We all need a bed, a buddy, and a job. We need safe and adequate housing. We need social support and pro-social activities. We need to engage in meaningful employment activities or structured activities. If you take care of this, it's quite possible with treatment, a lot of the justice involvement goes away if we just provide these basic services. But layering on the justice system makes it harder for folks to get housing, makes it harder for folks to get jobs, and makes harder for folks to obtain and maintain social support. But can our policies, can our interventions help these individuals, first and foremost, get a bed, a buddy, and a job? So a lot of my research has lately been focused on, let's put together interventions that are going to get folks with justice involvement who have SMI a bed, a buddy, and a job. So I'm going to talk about some of that for the next few minutes that we have together. However, let me pause here and see if there's any comments or questions. I will add, when I present this, I presented it recently, and somebody said, well, you really ought to add transportation too, particularly in rural areas where there's not a lot of public transportation, if any. And I thought we could add buggy, right? A bed, bed, buddy, job, and a buggy to indicate that folks have transportation needs. And again, as evidenced by the lack of a valid driver's license. All right. Hearing none, I assume I can only see a couple of you, given I've minimized the window. Go ahead, Cynthia.
Yes, hi. I'm an M.S.W student as well at VCU, and I just wanted to comment on some of the things you discussed. And some of your research reminds me of the ACEs study done by Dr. Harris, and how trauma can cause down the line, not cause, but be more associated with individuals having higher health issues. And then this right here reminds me of Maslow's hierarchy of needs, how we need those basic needs met before we can reach that top part of the pyramid and fully be a whole individual in a sense. So a lot of this is, you definitely painted a great picture. So I appreciate that.
Thank you, Cynthia. Right on. ACEs and also the basic needs. That's right on. I mean, got to be able to address the undiagnosed, untreated trauma and then meet these needs just to get folks started on recovery. And Rebecca?
Yeah, I was just going to ask, it's not necessarily about this, but when we were talking about the prison, the jails, and I was wondering if you ever did any research about, for sanctions in our program, one of them is research, is jail sanctions, maybe a day to a week. But there was a conflict one time. What would you say would be a good, did you do any research about how long a sanction would be for somebody with serious mental illness in jail?
Yeah, there is evidence. It's a good question that folks with mental illness stay longer in jails than someone without. So, and there's a variety of reasons for that. I mean, folks with severe mental illness, they don't have the resources to hire lawyers and get someone to advocate for them. And then sometimes they're disheveled, disoriented, experiencing symptoms in jails, which makes them harder to manage and maintain, and they stay longer. Sometimes they stay longer in jails because folks are working on restoration of competency while they're waiting for trials. So in terms of sanctions and charges, it's not necessarily the case that folks with mental illness for the same crime as someone without gets a different charge. It's that once they get in, it's harder for them to get out. They stay in jail longer, and then they have poorer outcomes when they're released.
Yeah, I was just talking about for the mental health docket that we do. I didn't know sometimes the sanctions.
Yeah.
They were arguing about what should be a good time frame for that, as because it's supposed to be therapeutic, but also like, but not the jail part, but it's like a team. But anyway, I'll talk to you later
Okay.
about that.
Well,
Because I'm conf-
that's a good segue, Rebecca, because one of my first intervention studies was with mental health court. This was in North Carolina, and the graduation rates, these are an older study, but probably still not that far off. Graduation rates are 50% or less, and typically substance use was connected with a bad mental health court outcome. And if you think about mental health courts, and the one I studied here, Rebecca, was 12 months, and I think someone described it, it might have been you, Rebecca, that the deal is you do this court voluntarily. At the end, if you're successful, they'll drop charges, and you meet monthly. You appear before the judge checks in with you, and the judge in North Carolina was a character, and he would say, Gary, I didn't get a good report this month. Bring your toothbrush next time you show up if I get a bad report, because you'll be spending some time in jail. So definitely sanctions were a part of this. This study was focused on implementing what's called dual diagnosis motivational interviewing. So it's motivational interviewing, as you might have guessed, that addresses both the psychiatric and the substance use at the same time. So I implemented this in a mental health court to try. Part of this was a reaction because mental health courts, if you think about them, are only as good as the service environments in which they're embedded, because they're service brokers. So if you're trying to help someone, but there's a 6-month waiting list to get into the substance use treatment, the mental health court is going to have poor outcomes, right? Because they can't do anything about access to service. So the idea was to equip court staff with some tools while folks were waiting to get folks engaged in services and to try to improve service engagement and get them to hang in there. Yes, Rebecca.
So in Fairfax County, the way that they do it is there's a level system, and based off of each level is determines how often you need to come.
Yeah.
So when you're on the lower levels, you're going every 2 weeks. And then as you go up in the level system, by the time you get to level 4, you're going once a month and you're going to get off the docket. Now, they don't guarantee that you'll be like, ideally, I think they're shooting for like 18 months. A year is like you've breezed through, you've got all the resources, but ideally they shoot for 18 months on the docket.
Excellent. Thank you. So there's a two-part study and an open trial part, but then really randomly assigned 50 participants. And what happened was the dual diagnosis motivational interviewing part was infused into the regular court intake. So we had 2 court staff. One did the motivational interviewing, the other just did the regular intake. Sure enough, the intervention was associated with better engagement over the short term. But if you think about it, the effect washed out after 3 months, and it really takes ongoing, particularly if folks are still waiting for services. They're not doing anything other than coming back to court once a month. So what really would have been more effective here, and for a variety of reasons, I didn't get a chance to implement the booster sessions, where every time a court participant would come back, the court staff would use the intervention again. For a variety of reasons, I couldn't do that. So it was promising in the sense that there was better engagement in both the court and local mental health services over the short term, but that effect kind of washed out. Part of it, speaks to what was the quality of those services, right? And what was the quality of those services and the ability for those service providers to keep folks engaged. So that was a local mental health court study. I'd be delighted to talk to folks about replicating this here, or at least providing the intervention. This is an oversimplification of the intervention itself. The court staff went with a change plan, and back in the day we had these carbon copies, right? I'm sure everybody remembers those. So the court participant would go home with one of these, and the court staff would keep it. And the idea was each time the participant returned, they would review, how have you done, Gary, with quitting or cutting down substances? How have you done with staying out of legal trouble? How have you done with participating in, and then use a motivational style to talk about the goals and the successes and challenges in each of these areas. So the interventionist would say, recovery is kind of like a three-legged stool. If any one of these legs were to fall off, stool's going to become unstable and fall over. So trying to resonate with the court participants. All right, so that's the mental health court study. Also been working on statewide mental health training. This was for probation officers in North Carolina. Would love to replicate this here in Virginia. But now, and this is kind of neat, where research actually impacted policy. You would hope it would happen more often than I think it does, but here it's now policy for probation officers in North Carolina to go through these mental health 101 training modules, and you can see them listed there. Severe mental illness 101 was the second module. Psych meds was the third. What is PTSD, personality disorders, other disorders? How do you find your local crisis response? So I've developed a couple more modules before I left North Carolina, so those aren't populated here, but there's one on trauma, one on substance use. Notably, the most popular module is the self-care for probation officers, where probation has a higher rate, relatively speaking, to other professions of suicide, given the high stress, high nature, high risk of that job. Did a little pre-test, post-test evaluation of folks who took the modules before and after, and found that mental health knowledge increased, which was good among those who participated in the modules, and also perceived stigma decrease, which is good because there's evidence that the less stigma you feel towards a person, the more likely you would be to engage and help him or her. So that's good, and kind of a neat result of meeting the needs of the state of North Carolina, who was a great partner and did everything that I recommended around, individuals with mental illness and probation. So it's neat to see these kind of results, and that policy came of it. The other thing that I've been working on for the last several years in particular, we're setting up specialty mental health probation units. And I started in North Carolina with just 2 counties. Now we're up to 34 counties. So these are specially trained officers. They have a reduced caseload. They have a caseload exclusively of individuals living with a mental illness. They have a problem-solving supervision orientation, greater interface with external resources. So trying to hook folks up with a bed, a buddy, and a job. The neat thing about this too, and innovation on the part of North Carolina, is they allowed a licensed clinical social worker to meet monthly with these officers to provide support, training, education, problem solve, and basically support the officers. So innovative and forward thinking on the part of North Carolina to allow this interface between a licensed clinical social work and the specialty mental health officers. So that was a study I did, and there's evidence that indeed these specialty officers were more likely to engage in getting folks connected to the bed, the buddy, and the job, and that probationers who receive specialty mental health probation, that's the green bar, were more likely to engage in mental health activities, among other things. Now, there wasn't an effect for substance use, mostly because all the officers are trained, they're hyper-focused on substance use, right? So both, especially officers weren't doing anything different around substance use, and the regular officers were already trained up to address substance use issues by nature of probation. A lot of these folks had convictions for substance use issues, so it was already a focus of these officers. All right. A study that I just finished, speaking of a bed, a buddy, and a job, is combining evidence-based practices. So combining supported employment, individual placement support, and supported employment, which is an evidence-based practice for folks with mental illness. The evidence is that it gets folks jobs. So the rate of unemployment I mentioned earlier was like 85%. IPS, supported employment, is effective probably 50, 60% of the time. So it really lowers that unemployment rate. So you know what you have to do when you're on probation? The primary thing that they tell you to do is go out and get a job, which is super difficult for someone with a severe mental illness. So it occurred to me, let's combine these evidence-based practices and see if we can address this thing that is really an issue that causes revocations, it causes sanctions, it causes problems for folks with mental illness. So I combined a supported employment intervention with especially probation. I just finished data collection on this, so don't have results to share yet. Learned a lot doing it though. First of all, particularly those folks coming out of prison, they need the basic needs. Maslow's hierarchy was mentioned earlier. Cynthia, they need a lot of stuff first before they can even entertain employment. The model IPS support employment has to be adapted to include other services as well, which it's supposed to interface with treatment and case management and some other stuff as part of a team effort. But these folks coming out of prison, they have nothing. And really the model needs to be adapted to accommodate the different needs. Rebecca, go ahead.
So in regards to like obviously like employment, helping them find employment is like a huge focus. Are there like, was it evidence on what type of employment? Because obviously like if they have a felony,
Yeah.
or depending on their charges, they're not going to be able to apply for
Yep.
certain jobs. So like how do you make sure they're able to find employment but have them applying to jobs that they kind of
Right.
stand a chance of getting?
That's a great question. And actually, we have an IPS focus here in the state of Virginia, and there's a group working on this. But to your point, Rebecca, the whole notion is kind of a job first mentality, sort of like housing first, that we're just going to get you into housing. May not be the greatest housing, but we're going to get you started. Similarly, with the job first approach, we're going to get you whatever you can start on. If it's Burger King or McDonald's or, you know, Walmart or a warehouse or whatever, let's get you started there and just get you working. Part of what IPS does too, it's someone negotiating with a potential employer. So, hey, Gary's coming out of, or Gary's on probation. He's got a mental illness, and I'd like to talk to you about potential employment. He's got this skill set. So all of that will be negotiated ahead of time in collaboration with the participant or the individual living with mental illness. So there's negotiation with the IPS team. Here's how I want you to disclose. Here's what you should disclose. Now, some jobs, right? People with, you know, certain felonies can't get it all. So somebody, you know, a bank, for example, is really reluctant to hire someone with grand theft or burglary or so forth. So it's a negotiation that occurs between the team, the employer, and the individual being served, with potentially building someone up to have a job that they matches their skill set. Going back into school or education is also part of it. That could be an element of it. All right. And then what I'm super excited about is a recent grant I got here in Virginia, and talk about bed, buddy, job, and then trauma. This is a study, and it's focused on, I'm going to say kids, but these are 18 to 20-year-olds who are in Bon Air Correctional Facility here in Richmond, right, who have behavioral health disorders. So these are kids who, for lack of a better way to say it, failed out of the local juvenile justice facilities. These are the kids who have the most profound issues. And the idea here is to put together a treatment team that's going to provide support and employment. We're going to do peer support and pro-social support, and also provide brief trauma care, anger management, skills that these kids need when they get out. We'll start serving them in the community, and then follow them serving them in Bon Air facility, rather, and then follow them into the community for up to a year to try to get them better community reentry outcomes, lower recidivism, which is pretty high, get them connected to treatment and advocacy and linkage. So I just got this project funded a couple months ago, and just really excited to get this started. It's a 3-year project. We're going to start out serving 75 kids. We're going to run the intervention hopefully out of the health hub on 25th in the East End, where a lot of these kids are going to end up, Richmond City, East End, Greater Richmond metropolitan area. So it's got all the elements that I've been talking about as I think about these criminogenic risks and what these kids need coming out of Bon Air. This is intentional to try to cover as much of that as possible and try to give these kids a fighting chance, no pun intended at all, but give them a fighting chance to have better community reentry outcomes. So I'm super excited about this. It's my first Virginia project, and looking forward. It involves multiple disciplines here at VCU. The School of Ed and the Research and Rehabilitation Training Center is involved. The College of Health Professions and Council Rehab is involved. And then I'm going to work with local agencies who are already working with kids in Bon Air to figure out some of the elements of other services. So super excited. And Project Belong, that acronym stands for something. I know I made it up, but I can't recall exactly what it all means, but you'll have to trust me that it means something. All right. And I think that is it in terms of the slides. So let me stop sharing if I can. And then let me see if I can get everybody. Did I stop? Thank you. Okay. So Jessica.
I was glad to see your last slide, because something this has had me thinking about, and part of the reason I signed up for this is I have been helping a friend whose young daughter committed offenses that required intensive residential treatment, and finding any kind of support for this child has been almost impossible. She's like on the other end of the state now. But because it's a young girl who is an offender, it was nearly impossible to find like support. And that just then snowballs, like when you can't get that most like the intro support needed when the problem is still manageable. It's an overwhelming problem, and I'm thankful people like you are trying to tackle this.
Indeed. Thanks for that comment. Yeah, I hope this really gains some traction, and that we're going to study the impact and outcomes of this, and hopefully it can serve as a national model of what to do. It's got these elements that address these criminogenic risks that these kids have, and if it works, it could be something to adapt and disseminate. So thank you for that. And then Cynthia.
Hi, yes. So with your last slide, it's got me thinking, and I'm not sure if we'll discuss this in the series, but if we do, you don't have to answer now. I'm patient enough to wait for, till we learn. But I was wondering if you had any advice on how to assist a young youth who is in and out of acute treatment, who attempts suicide frequently, to return back to those facilities, because that's where they're most comfortable with. That's your presentation kind of got me thinking about that too, as well, with individuals with severe mental health issues. They do return to the criminal justice system or other mental health facilities frequently, sometimes not on purpose, but with the intent to, because they're provided that care, food, housing, and also treatment. So how can we address that in a sense that they don't return to those facilities and they stay in the community and receive the treatment, battling the fact that they want to kind of go back?
Yeah, that's a great question and a great comment. We do have one of the sessions, Stavara, correct me if I'm wrong, but it's focused on suicidality. But then I think,
Gary, I'm going to jump in. Sorry, it's Cassie. We have two coming up. We do have one that's focused entirely on suicidality and psychosis with an incredible person coming from NYU, and this is their area of expertise. And we do have another one that's going to be about teens and adolescents, and I do think it's going to talk, Cynthia, a lot about what you're saying. So Gary, I want to let Gary talk about this too, but we do have 2 sessions that are going to hopefully, as they're planned, touch on what you're saying.
Thank you, Cassie. Glad you're here. Go ahead, Cynthia. Do you want to say?
Yes, I was just going to say thank you, Cassie and Gary. If you want to input, if you want to add anything to what we may learn later, that's fine. But if you want to keep it short and simple too, just because we're going to learn it later.
Yeah.
Whatever you.
Thanks. And I would say, I'm going to sound like a broken record, but the bed, the buddy, the job, right? I think the trauma focus and persistence, right? Especially as middle-aged and older adults with these disorders have been failed, if you think about it, for all, for all of our systems, right? They're mistrustful of treatment. They've been failed by the community mental health system, substance use, housing, and then the justice system. So breaking through that cycle and that pattern, I think, takes time, and services, undiagnosed, untreated trauma being a part of that too. And Cynthia, I think your point was right on, that some folks get institutionalized, or they feel more comfortable in institutional settings where things are more predictable, their needs are met, and we don't have the resources or the care on the outside. So, and thank you, Cassie, too. We'll learn more about these things during our other sessions. All right, Nancy.
Yes, Dr. Cuddeback. I wonder if you could talk a little bit about the intervention part of the Project Belong.
Yeah, only if you call me Gary.
All right, Gary. Thank you.
You bet. Thank you for your question. Yeah, so really it was conceptualized by thinking about, what are the things that folks need to be successful after being released from institutional settings, right? So I'm going to go back again, sound like a broken record. Let's get folks a bed, a buddy, and a job. So what evidence-based treatments or practices do we have that we know are successful at doing those things? So supported employment to connect with these kids is an evidence-based practice that is going to work, as I said a moment ago, with employers in the community, but also the kids, to get them ready for jobs. And then once they're in those jobs, to continue to support them. Then there'll be case management features to get them connected to safe and adequate housing. And that's a difficult thing, because we all know, we all know there's plenty of housing, and you'll get what I'm saying in a moment. There's just not affordable housing, right? In my area, I live down in Chesterfield. They're building like crazy. I mean, it's ridiculous, but it's not affordable, for folks who are living on SSI or supplemental security disability, right? Social Security disability. So it's not a housing problem, it's an affordable housing. So when I thought about the intervention, Nancy, I think, what components do we need to add? And then certainly based on prior research I've done, addressing the untreated, undiagnosed trauma that results in impulsivity, anger issues, the kind of things that are going to lead to criminal legal involvement. So that's the way I thought about putting together the intervention. What components do we need? And then typically my model is to go find somebody who's doing this stuff. So I'm not going to, I'll find an agency that's doing the peer support, credible messenger interventions, rather than hire someone at VCU, or I'll find someone out in the community that maybe is already working in Bonaire on trauma, right? So that's typically my model, rather than develop the capacity at my university. I'll contract, or I'll work with community agencies that are out there already doing the work. So let me pause. Nancy, is that how else can I answer your question?
I think you did a pretty good job of covering it. And so I got the part about the bed, the buddy, and the job. And so I was more curious about the mental health component.
Yeah.
And, you really addressed that by saying that you're going to use contractors who are going to provide that kind of support, the anger management issues, how to keep somebody persisting in a job if they're having panic attacks, or, whatever their issue is with employment.
Yeah. And there'll be case management. Yeah. Case managed components will have I hope to develop here a multidisciplinary, here at VCU, a multidisciplinary internship program where, I mentioned disciplines that were involved in Project Belong. So we've got rehab counseling, we've got school ed folks, there's folks from criminal justice department at the Wilder School. So what I'm conceptualizing is a multidisciplinary field placement where students from each of those disciplines are learning from each other. So they're better equipped when they hit the community, because unfortunately, no matter where you work, child welfare, school, you can't avoid someone who's got criminal legal involvement, right? Either directly or family member or so forth. So we need to better equip our students, in my opinion, at least, to have a breadth of knowledge in all these different areas. So I say that, Nancy, because I hope that in getting these students engaged in providing some of the case management, so create a field placement out of this project. And that'll be linkage and advocacy to connecting mental health and so forth.
That would be excellent, because I think sometimes what happens is all these different specialty areas are so siloed that we don't network very well. We don't work very well together to support the individual.
That's right on. And, when I went through my M.S.W program years ago, there was no discussion at all of engagement with the criminal legal system at all. And I had no training. And even when working at UNC, I developed a mental health criminal justice course because there was none. So I think our professional schools of social work still need to do a better job, right, of multidisciplinary training. All right, Katie.
Hi, thank you so much. I'm a student at VCU as well. I'm an M.S.W student. Graduated as a Tar Heel, probably before you were there. But, yeah.
I won't ask you what year, but I'm interested in who was on the basketball team when you graduated, but don't answer.
Dean was still coaching, so.
All right.
If that gives you any clue.
It does.
For a few years after too.
Okay.
I mentioned this, and Dr. DeSena Jacobs very kindly responded with the Virginia LIS for the behavioral health, but I didn't know if you mentioned policy changes, and I didn't know if there were particular policies that you're aware of this year in the legislature that are like high priority, or things that we could be advocating for in the General Assembly, since they're meeting right now.
Yeah, I don't, although now that you say that, Katie, I did see something circulated. I can't remember the organization, just highlighting some of the policies that the legislature is continuing. I don't know of any specific that are of particular import. I will say, the governor's initiative, and I'm going to help me with the name, right help right now. I forget.
Yeah, I think that's it.
He focused on, I think, more mental health and attending to mental health, and mental health services is a priority here in the state, as far as I can gather. So someone from the governor's office recently reached out here. This was interesting, to social work and psychology. And what they want to do is marketing and digital advertising to try to get college age students involved in mental health disciplines so they can go join the workforce. So what's going to happen through the VCU Brand Center is they're going to interview some students and try to come up with a marketing campaign. So it's not a direct answer to your question, Katie. I know that the governor is thinking about it, and I hope there's important legislation that is being considered around access, utilization, more services, and then also bed and buddy and a job, right?
Yeah.
Yeah. And if anybody knows, what's out there or what's on the legislative table, if you will, please.
Yeah,
help.
I mean, I could probably, if you think of an organization, even just a nonprofit that's working for criminal justice reform, I could probably figure that out, look for some, and see what they recommend right now. So
I do know one. I was just looking to see if it was doing anything this year. The Virginia Interfaith Center for Public Policy. They have 4 different things they have right now that they on their website.
I'll check it out. Thanks. I know them. Yeah.
All right, Dana.
Hello. Thank you so much for your talk. It was wonderful. I wondered if you could talk a little bit about the intersection of severe mental illness and either like maternal mental health with like postpartum psychosis or just about those folks getting access to additional care and treatment?
Yeah, great question. Yeah, I mean, women with severe and persistent mental illness are mothers too, right? And it's been a population that is more likely to have, children removed from their homes. They're more vulnerable, as I said, to interpersonal violence and um, Dana, a woman with a mental illness like bipolar disorder or schizophrenia, I don't know if I've seen any research, and if someone has, please let me know, but the increased likelihood of postpartum depression, I don't know about that, if those two things go together. Often the case, and I'm recalling this now, um, uh, uh, women who do with severe mental illness who are on these psychotropic medications will often have to go off them during their pregnancy. And then think about that and the level of care that they need to remain stable and the support that they need that they often won't get. Forget it if they're involved in the criminal legal system. So when you add pregnancy and reproductive age moms or women, it layers on a whole host of things. And again, all of the issues I mentioned about the physical health problems and the lack of access and utilization, I think would extend to maternal and child health care as well. So great question. It's not an area that I have really focused on my research, but I think it's really important. So thank you. And then Dana Posey.
Hi, Gary. Thank you for taking my question. I was just curious. I am a case manager at a CSB. I'm also an M.S.W student in Virginia. I was curious if your data ever looked at dual diagnosis from an IDD perspective. Did you include that in your research at all? That's a passion project of mine because that's kind of my field. And then I also was curious to know if you looked at mandatory sentencing and if that improved like symptoms of mental illness in jail, and did that decrease recidivism because you had a stability of treatment?
Yeah. I'll answer the second part first. I haven't looked at the impact of mandatory sentencing or structured sentencing on and how that possibly impacts. And I think that's a good question. And a lot of it has to do with the sophistication of the treatment and whatever facility they're in, right? Hopefully these folks, particularly in prison, get identified and then go to special justice facilities. That one of the most sophisticated psychiatric units I've ever seen, unfortunately, was at Central State Prison in Raleigh, North Carolina. I mean, it was a remarkable state-of-the-art facility, which was sort of for North Carolina, was the central location for folks with mental illness. So if they were screened at the diagnostic unit, then with a mental illness, they'd end up there. Sort of independent of the question you're asking, though, about mandated sentencing. So haven't looked at that with my research. The first part of your question was right on. Matter of fact, I'm writing a proposal now to look at the incidence and prevalence of IDD and SMI. We know very little about that population. That if you think of the disparities in access and utilization of care for IDD and the disparities in access and utilization of care for SMI, then you put them together, that exacerbates disparities. So the study I'm proposing that'll be, I'll submit next month, is to look at the incidence of the configuration, the service needs, some focus groups with families of individuals and, disparities in their access and utilization, and then hopefully pilot family health navigator intervention to try to improve utilization and access for this population. So something I've been interested, there's not a lot written about the comorbidity of IDD and SMI. Some of our most intensive treatments for SMI, for example, assertive community treatment, excludes folks who have right. So there's no treatment for both of those things at once. So it's a remarkable gap in our service system for this, I would argue, a high risk, high need population where probably families are left, with little support, little resources, little information. So thank you for that question.
And Gary, we have time for one last question before we wrap up for the night. And so Rebecca will allow you to provide the last question.
So it's not a question. I just wanted to piggyback off of the maternal and fetal, what we were talking about previously. Just I have personal experience. Just I have had a child within the last year. And in regards to like medications and taking medications while pregnant, unfortunately, there is not a lot of research that indicates whether the medicine will affect the baby, will have any effects on the baby, because unfortunately you can't do a research study on pregnant women. But I do think it is interesting to see if there could be research for after pregnancy to see the effects of, because while there's baby blues, there are some people who really do go into psychosis after had a baby who have serious mental illness.
That's a great comment, and lots of work to be done there too. Well, I want to thank, go ahead, Savara.
Go ahead.
This has been terrific. The participation was great. I really appreciate the comments. It's great to see VCU students. It's great we had a Tennessee grad there, go Vols. UNC, Katie, sorry to date you with the Dean Smith reference. But this was terrific. And as Stavara said, the launch of our series, and as Cassie mentioned, we've got great information and great topics to cover. So I hope you come back. There is Stavara, do you want to say anything about that evaluation?
Well, first, we want to thank you for leading off our session tonight for our webinar series. I did want to share one last thing. Please make sure you've done the attendance sheet so that way you can get credit. We will also be sending an evaluation afterwards where you all can tell us what more topics you might want to see if we continue this series, when we continue this series this fall. Also wanted to share that we do have an SMI elective in the M.S.W course. And there was a question raised about SMI and postpartum, and Dr. Jacobs has provided information in that course with the current research in that area. So just wanted to plug that out there. So if you want information about that elective, how to register, when it's going to be offered, please feel free to reach out to myself or Dr. Jacobs. And with that, we'll close it out. Thank you, Gary.
Thanks, everybody. Have a great night.
Thank you.
Thank you so much.
Thank you.
Thank you.